Let's do some quick ones. I've had the privilege of teaching upper and lower extremity mechanics to medical students and understanding gait and posture and how the feet and legs work. When I was a professor, I started out the first year course with a discussion of comparative anatomy between higher apes and humans and what we call striding gait and how the muscles of the hip bones and the pelvis work differently in bipedal lower primates and humans. Now, that was because that gave me a doorway to lead into the concepts around muscle spasm and somatic dysfunction. And then as we understood leg and hip mechanics, that was a natural segue or flow into how the lower back worked to mediate those forces that were coming up from each leg as we stride. One of the things that I started with, though, that is an important factor in medicine that is often skipped over is how the feet distort and cause all kinds of problems in the feet and knees and hips that are not recognized when a patient presents perhaps with lower back or hip pain. If we sprain our ankle and we stretch out the talofibular ligament, which is on the outside of the ankle, that destabilizes the arch of the foot. This is called Morton's syndrome. And what happens is the arch of the foot elongates a little bit, but most people have pretty healthy long arches, and their long arch doesn't really collapse when they start to lose the arch mechanics. But what does collapse is called the transverse arch, and that's across the forefoot at the base of the toes. And when that arch collapses, the bones on the end of it that go to the great toe and to the little toe roll in and convert a hinge joint in one axis into a diagonal axis, and you get a bunion on both the little toe and the big toe, although the big toe gets all the attention. And with that deviation of the angle of the toe comes an altered foot mechanic, because you no longer go heel to toe as you push off. Now you have to also add an element of rotation to it, because as the arch collapses inward, you pronate or roll the extremity inward. That torques the knee, which is supposed to be a hinge joint, and creates a torque in the knee. And this is called tibial torsion, because tibia is the main bone that transfers this force. But this sets the knee up for problems. So the most common long-term effect of an ankle sprain is a sprain of the knee. And this happens because as they pronate, what is the tightest point in the knee? If you rotate it, the medial collateral ligament. So as they pronate from the ankle, it sets up the knee for a tear of the medial collateral ligament. It also sets up the kneecap for dislocations in young people like 12, 13, 14-year-old kids. These are the children that have flat feet that pronate and dislocate their kneecaps. If the dysfunction goes on, it spreads from the knee, torquing into the muscles in the hip that control the rotation of the femur. So this is how a problem in the foot can spread to the knee, to the hip, and to the lower spine. Now, one other thing before we leave these ideas, and that is that the most underrated bone in the body is the fibula. Now, the fibula is a very important bone on the outside of the shin, but what it is supposed to do is transfer the force from your toes as you shift your weight from the heel over to the side of the foot to push off and really trim your body motions and control them more precisely. And that's what these toes are supposed to do. But when you pronate, you shift your weight over, and what happens is the fibula, the little bone on the outside of the leg, gets torqued inward, and the head of it gets stuck forward. So when they go to lock their knee at full stride, they can't lock the knee, and it makes them start to alter their gait. So it sets them up for all kinds of strain problems in the fibula, the ankle, and then that torques the hip differently, and so they have problems in the hip, and it all comes from the foot and Morton's syndrome. Every day in this country, orthopedic surgeons and podiatrists remove Morton's neuromas. But Morton's neuromas are a result of the collapse of the transverse arch and the torquing of the metatarsals. And if you restore the transverse arch by putting a metatarsal pad in and lifting it back up, the bunion goes away on the little toe and the big toe. The Morton's neuromas don't form. the arch mechanics are restored and the patient doesn't pronate, and it doesn't. That's why you keep them from having knee problems and hip problems later. Be aware that collapse of the transverse arch is the most common cause of ankle and knee problems. What is the most common cause of lower back pain? Well, when you're training osteopathic medical students, the first thing you teach them to do is assess iliac crest heights. And the reason for this is this one little factoid, which I'd like to present to you. Now, asymmetry, where the right and left side of the body is not perfectly matched in size, is normal. And 80% of people have a tilt of their pelvis to one side or the other, so like 5 millimeters, 3/16 of an inch. So some asymmetry is common, and that 80% of people have that much asymmetry. But consider this, in chronic pain, 95% of patients, 19 out of 20, have greater than a 5/16 inch tilt to the pelvis to one side. Here's where it gets cool. If you put a lift in the short leg side and level the sacrum, 60% go pain-free with nothing else, no manipulation, no pills, no nothing, just restoring balance to the sacral base. That alone will reduce the pain that much. And 80% get better and are able to significantly reduce their need for narcotics or pain medicines or further treatment for that matter. So while, and I have seen many times that leg lengths were overlooked in a patient's assessment before surgery for lower back problems or disc problems. Even in the neck, the asymmetry in the pelvis and the pelvic imbalance can cause a disc syndrome to go on and on and on. So remember that the most commonly overlooked factor in lower back pain and in neck pain is leg length difference.